Good evening, everybody. I would like to thank Dr. Chaja and the organizing team for having me here today. So today I'll be talking on malignant pleural effusion. Where are we now? So malignant effusion occurs commonly with lung cancer, breast cancer, and lymphoma. Although 50% of metastatic cancers have malignant pleural effusion as well. For diagnosis, we see particularly on contrast enhanced CT scan, nodularity in pleura and thickening of pleura of more than 1 centimeter, especially mediastinal, parietal, and circumferential pleural thickening. The PET CT has moderate accuracy for diagnosis, as we all know that even granulomatous diseases, reactive pleuritis can be avid on PET. Cytology of the pleural fluid, biopsy. Biopsy is a gold standard. Close biopsy, image guided and open, which is thoracoscopically. Medical thoracoscopy has a high diagnostic yield, and at the same time, pleurodesis can be done. Pleural fluid now can also be used for next generation sequencing as well as molecular study. This study shows around 108 pleural fluid samples of advanced lung cancer undergoing next generation sequencing. Of these, 86% had EGFR mutation detection. And ALK was detected in 6 patients, ROS in 1 patient, and KRAS mutation in 4 patients. So this tells us that if we have patients where a repeat tissue diagnosis is not possible, we can go for the malignant pleural effusion sampling. So a lot of prognostic scoring systems are there, but the LENT score is the most reliable one. This includes pleural fluid LDH, ECOG scale, neutrophilic lymphocytic ratio, and the tumor type. So risk stratification is low risk includes a median survival of around 300 days, moderate risk includes a median survival of 130 days, and high risk includes only 45 days of median survival. Management options include thoracocentesis. This can be done repeatedly. It helps to ascertain the underlying lung expansibility. We have to limit at one time around 1.5 liters of aspiration to reduce the risk of pulmonary edema. Of course, repeated aspirations also lead to risk of septations and infections. Pleurodesis can be done in 2 methods, mechanical or chemical, but it is contraindicated in non-expanding lung and multiloculated effusions. Mechanical pleurodesis is done during thoracoscopy. Mechanical ablation, parietal pleural peeling, and even studies are there on laser and argon beam coagulation. Chemical pleurodesis, which is the intrapleural administration of various agents, can be done via the chest tube also and thoracoscopically. Larger chest tubes are associated with a better chance of pleurodesis, and use of NSAIDs has no effect on time to pleurodesis. These 2 points are highlighted in the Time 1 trial. Sonography may be used to check the apposition of pleurae, and this also reduces the time in the hospital for pleurodesis. This was highlighted by the SIMPLE trial. The choice of agents includes steritalk, bleomycin, tetracycline, iodopovidine. The success rate for talc ranges from 81 to 100% and bleomycin from 58 to 85%. Graded preparations of talc should be used instead of small particles to avoid the risk of ARDS. A meta-analysis of around 10 randomized studies found that there is non-recurrence of effusion when talc was the agent used over other sclerosins. This study, which is a multi-centric randomized control study of 330 patients, they were randomized into either receiving 4 grams of talc via slurry by the chest tube or via podraj. And the primary endpoint was to see the 90-day failure rate of pleurodesis. As we see that both the groups, one is 22, the other is 24%, statistically there was no difference in either of them. Intrapleural fibrinolysis is indicated for loculated and septated effusions. Urokinase, streptokinase, and tissue plasminogen activator can be used. However, as per the Time 3 trial, there was no effect on the clinical outcomes such as dyspnea and pleurodesis rate. There was only improvement in the radiological appearance and volume of drainage fluid. Indwelling catheters, which has now been around for over a decade, they're intended for long-term management. They're associated with shorter hospital stay than chemical pleurodesis. They're also associated with autopleurodesis. They're a simple silicone tube, which can be tunneled into the pleural space via the Seldinger technique subcutaneously. And at the end of the outer end, there is a one-way valve which can be connected to the drainage bottle and repeatedly drained. This is done as an outpatient procedure. This slide highlights the various landmark trials which have occurred for the management of pleural effusion, malignant pleural effusion. And the most recent ones are now focusing and combining all these techniques that we have discussed. So the Time 2 trial, again, one of the landmark trials in which IPC versus ICD and talc slurry was assessed. The primary outcome was relief of dyspnea. So the results were that dyspnea improved in both arms. There was no significant difference. IPC was, of course, associated with a shorter hospital stay. However, the adverse effects were higher and the pain profile was same in both the arms. The ASAP trial, which included 149 patients randomly assigned into either daily aggressive drainage via the IPC or alternate day drainage, primary outcome was to check for incidence of autopleurodesis. As we see that the daily aggressive drainage group was known to have a higher rate and also a shorter time to pleurodesis. So this trial includes 154 patients. This is the IPC plus trial. It's a multi-centric randomized control trial receiving 4 grams of talc versus placebo, but via the indwelling pleural catheter. The primary endpoint was to check a successful pleurodesis at 5 weeks. We see in the talc group, the success rate is 43%, whereas 23% in the placebo group. This is some new data that has come out regarding silver nitrate coated IPCs. So this study includes 114 patients randomly assigned to either silver nitrate coated IPCs versus standard IPCs. And the outcome was to check pleurodesis rates at 1 month without recurrence. We saw that 32% in the standard IPC group versus 22% in the silver nitrate coated IPC groups achieved pleurodesis at 30 days. So this study says that silver nitrate coated IPCs are not superior to the standard ones. IPC also has its complications such as infections, catheter-related metastases, which are common in malignant mesothelioma, intrapleural loculations, and catheter blockages, catheter fractures. Adding some new dimension to the management, this recent study done in January 2022, where hyperthermic intrathoracic chemotherapy was used for treatment of around 169 patients of breast cancer and 8 patients of ovarian cancer having malignant pleural effusion. Symptomatic control was found in 59% of the breast cancer patients and around 87.5% in the ovarian cancer patients at 4 weeks. However, in this study, survival data was not analyzed. Whether these kind of management is yet to have any holding, I think more studies are required for us to know. Thank you.
Thank you very much. We invite the last speaker,